We haven't quite hit noon. Just going to give people a chance to join. And just remind people that there is the hybrid option. We are in room D212, 1312, and there is a lunch and some fruits and healthy foods. All right, why don't we get started? Thanks everyone for joining us for McGill Department of Medicine Grand Rounds. Before we go on, we'll start by acknowledging that McGill University is situated on unceded territory of the Kenyan Gahaga and located on land which has long served as a site of meeting and exchange for Indigenous peoples, including the Haudenosaunee and the Nishtabé nations. I ask that make sure that you mute your microphones, and we invite you to unmute during the question and answer period and or put in your comments in the chat. One commercial message to plug the Rising Star in Medicine Gala at the Ritz on May 9th in the evening. Be a fantastic event with door prizes celebrating our up-and-coming scientists and DJ, etc. And I'll now call on Dr. Alain Bitton, our Division Director for GI, for a few more weeks to announcement coming there, by the way, on that, to introduce our speaker, Dr. Sebastiani.
Thank you, Mark. So it's a great pleasure for me to introduce my esteemed colleague, Giada Sebastiani. So Giada is Professor of Medicine in the Division of Gastroenterology and Hepatology. She's been a very successful clinician scientist with FRQ-S salary funding, CIHR funding for her research program, and very well published. She currently is the president of the Canadian Association for the Study of Liver, and she is truly internationally recognized as a leader in the field of MASLD, liver fibrosis, and non-invasive diagnostic markers for liver disease. In fact, she established the first diagnostic center in the province, and we're truly proud of that. So, Giada, welcome to Grand Rounds, and we look forward to your talk on MASLD.
Thank you very much. Thank you very much, Alain and Mark. First of all, I would like to thank Mark and Nadia for the introduction, for the invitation, and Alain for the kind introduction. Such nice words to me. Thank you very much. So, MASLD is really my main focus of my research program, and as Alain has said, actually we are involved in many international guidelines with this very frequent condition, which you will see is actually at the crossroad of many specialties in the realm of medicine. These are my disclosures. So the first and most important thing is that MASLD was once upon a time called this entity, now changed a couple of years ago to the new nomenclature, which is MASLD. The idea was that MASLD was actually an exclusionary diagnosis. You had to exclude alcoholic liver disease, viral hepatitis, but it didn't really put the emphasis on the main risk factors for this condition, which are the metabolic risk factors: overweight, obesity, diabetes, dyslipidemia, and hypertension. So there should be now, with the new nomenclature, hepatic steatosis, so a surcharge of fat, an overload of fat into the liver of at least 5%, and at least one of these metabolic conditions. So this really puts the emphasis on the very close link between fatty liver disease and metabolic syndrome. And you can see here an overview of the steatotic liver disease new nomenclature. You see on the left MASLD, but I think it's also very important that in this new nomenclature, there is also the possibility of having MASLD steatosis together with some quantity of alcohol intake. I mean, in our clinical practice, there is never just a patient who has fatty liver disease without any alcohol intake. They are not not very frequent. So this actually new nomenclature also put more emphasis on the real cases that we find in our clinical practice. But now we will focus for the rest of the presentation on MASLD. So what are we talking about in terms of disease burden? This is the global burden of liver disease in 2023. And you can see actually that the current worldwide prevalence of MASLD is at 32.4% in the general population. It means that at least 1 in 3 in the general adult population is actually affected by MASLD across the globe. The percentage of total deaths from all causes attributable to MASLD has increased from 0.10% to 0.17% in the past 10 years, which it means really almost doubled. And currently, MASLD represents the second leading cause of liver transplantation, but it is also the leading cause among females. So a very important disease burden. And this is a study that we recently published in Journal Ep Reports in 2025, where we actually looked more specifically at the burden of the condition across the various geographical areas. So we recognize with this publication that MASLD is a global health issue with the highest reported prevalence in Kuwait, Egypt, and Qatar. Men have a higher prevalence of MASLD than women, with peak prevalence occurring at different ages depending on the sex. However, women seem to be more affected in terms of years lived with disability. So this is a very impactful condition. And which are the main drivers? We already discussed that the own definition in the condition, actually, of this liver condition encompasses also the prevalence of metabolic factors. And for sure, the increase in this condition in terms of prevalence has been driven by the increasing rates of obesity across the global population. You can see here that if the prevalence is 33%, there are also reports of 38% prevalence of MASLD across the globe. The prevalence actually rises dramatically in patients living with obesity at 80-90%, and patients living with type 2 diabetes about 70%. So these populations are particularly affected by this condition. And this is a study that we recently published, which show indeed that BMI is the leading risk factor contributing to liver cancer attributable to metabolic risk factors. And this is both in females and in males. So all this epidemic for sure has been driven by the increasing rates in non-communicable diseases, including obesity and type 2 diabetes. What about type 2 diabetes? We know now that type 2 diabetes is most likely the most important risk factor for liver fibrosis and cirrhosis due to MASLD. We know that there are 436 million adults around having type 2 diabetes. 65% of them have MASLD. And you can see that also in this case, also in people with type 2 diabetes, the prevalence of MASLD has increased progressively in the past years. And we will actually look into more details on the link between type 2 diabetes and MASLD. What about Canada? So we spoke the big picture, the big epidemiological picture across the globe. What about Canada? This is a study, the first study that we published 4 years ago in CMJ Open, where we wanted to try to look at the modeling of the burden of MASLD in Canada using Markov model. So based on the projection on increasing in rates of obesity in Canada, we actually could look at possible modeling of the increase in MASLD prevalence in our country. So we projected that by 2030, prevalent MASLD cases will increase by 20%, prevalent MASH cases will increase by 35%, and more worrisome, prevalent compensated cirrhosis MASLD cases and prevalent decompensated cirrhosis liver transplant HCC will actually double in our country by 2030. So this means, I always say, like we are in a beach, there is a huge tsunami coming towards us, and we have to try to put some margin in some way, and we still are thinking how to put this. So now we can actually look at also some very recent data. We just published this paper. This is actually the first study in Canada which looked at specifically estimate prevalence of hepatic steatosis and advanced fibrosis through the use of simple biomarkers, which are relatively easy to measure in the blood, the hepatic steatosis index and the NAFLD Ridge score. And we actually we used the estimate through the Canadian Health Service measure survey, and we concluded that the prevalence of hepatic steatosis in Canada is currently between 38 and 48%, and the estimated prevalence of fibrosis in patients with hepatic steatosis is anywhere between 1.2 and 2.5%. So this is really giving us really the magnitude of this condition. But now, epidemiology is quite rampant in terms of the importance of this condition. So, which is the physiopathology of this condition, the pathophysiology of this condition, and the natural history? From a liver which is healthy, the first step is for sure having fat, steatosis in the liver. This, when there is a development of inflammation, will actually give MASH, metabolic dysfunction-associated steatohepatitis, which means fat with inflammation. From this, it can become scarring, significant fibrosis, cirrhosis, and hepatocellular carcinoma. The physiopathology of this condition is the classical multifactorial disease where there are many hits that causes the condition, the progression of the condition. There is for sure some genetic predisposition. For example, we know that people of Hispanic ethnicity are at high risk of MASH and fibrosis progression compared to white and black people. But on the other side, there are for sure also lifestyle. Environment is very important. Lifestyle, snacking, fast food, also gut dysbiosis, there is also a role on that. So it's the classical multifactorial disease where everyone can progress in a different way. So the natural history of the disease is quite individual, and we will actually look at the main risk factors for that. And we already mentioned that here is, and these are actually underestimated prevalences. We think that at least 8 million people in Canada currently live with MASLD, with steatosis, 2 million with MASH, 600,000 with significant liver fibrosis, and 300,000 cirrhosis due to MASLD. So these are the numbers that we talked about. But beyond the multifactorial progression of the condition, diabetes and obesity remain the strongest predictors of advanced liver fibrosis in people living with MASLD. We know, for example, that from the NANES data, the odds ratio of having advanced liver fibrosis in people having type 2 diabetes is 18, and in those living with obesity is 9.10. So obviously, these remain the most important risk factors associated with fibrosis in people living with MASLD. And I like to call the association between type 2 diabetes and NASH-MASH the perfect storm. You can see the huge wave that I mentioned before. So it's really a bidirectional association where the presence of type 2 diabetes is an independent risk factor for the development of MASH. It actually speeds up the progression towards fibrosis and cirrhosis, and people with type 2 diabetes have also higher rates of HCC, liver cancer, and cirrhosis. On the other side, presence of MASH in people who don't have type 2 diabetes is actually a risk factor for developing type 2 diabetes. And in those who have type 2 diabetes, the presence of MASH actually worsens hyperinsulinemia and also reduces the response to anti-diabetic treatment. So it's really a very close, very neat association. On the other hand, I think it's important in our clinical practice to know that BMI doesn't always mean metabolic health. And actually, there are many researchers showing that BMI is an imperfect actually index for metabolic health, and also specifically in the context of MASLD. In fact, there are actually obese people who are metabolically healthy, which means there is no diabetes, hypertension, or hyperlipidemia. On the other hand, there are metabolic and unhealthy lean people. So, and actually lean MASLD is becoming an important entity in those who study MASLD, because there are emerging data showing that people with lean MASLD have actually an increased risk of overall mortality, mostly due to cardiovascular risk, probably for the presence of visceral fat, epicardial fat. We had actually a cardiologist recently at the Canadian Liver meeting who provided a wonderful overview on how in lean individuals MASLD can be quite deadly. And here is a publication that we did last year where we formulated a framework for understanding MASLD in individuals with normal weight. And probably the reason why there is lean MASLD is that there are disparities in metabolic adaptation between lean and obese individuals with MASLD. Obese individuals with MASLD have suboptimal metabolic adaptation, while lean individuals with MASLD exhibit an obesity resistance phenotype. And another important point on MASLD is that MASLD is a classical sex dimorphic disease. There are clear differences in men and in women. For example, we know that men have more insulin resistance, that men have also more triglyceride synthesis. On the other hand, ladies have more fatty acid oxidation. So all these differences actually cause MASLD to be different across biological sex. Generally, the prevalence of MASLD is higher in men. However, women of reproductive age have a lower risk of MASLD compared to men, but after the menopause, the prevalence actually increases in women due obviously to the loss of protective effect of estrogens. So it's very important to know that while it is actually ladies and women have less risks before the menopause, the risk actually increase after the menopause. And indeed, in this presentation by one of my students, we showed that at the critical biological age, there is an increase in fibrosis progression in women. Also shown by this study, where we showed that MASH, MASH MASLD exhibits sex-related differences after menopause. You can see in the red line that while before the prevalence is usually lower, there is an acceleration when the age reach close in the critical biological age of women, which is between 50 and 55. So this is very important to be informed. Another important research that we conducted, another of two of my students here, we just published, is that of course, there is a big issue also of socioeconomic status related to MASLD and food insecurity. We say that we have to eat healthy, and we tell patients that we have to eat. And we have to eat healthy, but of course, not all of our patients can actually access healthy food. In this study, in over 800 people with HIV, we actually looked at how material deprivation affects adverse liver outcomes. And we found, first of all, that materially deprived people are more, for example, among females, are more among people with type 2 diabetes and among non-white people. And in this study, we showed that people who are materially deprived actually have more adverse liver outcomes, clearly shown the importance also of considering socioeconomic consideration in our patients. And now, MASLD, we focus until now on the importance of the liver, like a liver-focused, liver-centric view. But I think that when we speak about MASLD, it's always important to remind that this is a clear multi-system disease. We know that MASLD is based on a chronic inflammatory milieu, which actually causes MASLD to be associated to a myriad of conditions. For example, you can see here a few: malignancies, osteoporosis, psoriasis, polycystic ovary syndrome, chronic kidney disease, sleep apnea, and so on. And all these associations are actually independent. For example, chronic kidney disease, the association is independent by the presence of type 2 diabetes. So it's really a causal kind of association. That's why the management of MASLD should always be targeted by a variety of stakeholders. And the major cause of death, actually, in people living with MASLD is not liver. Liver is just the second, but it's cardiovascular disease. In fact, guidelines recommend that cardiovascular complications should be taken into consideration, and screening of cardiovascular system is mandatory in all people with MASLD, at least by detailed risk factor assessment. And the MASLD and the fatal triple is a clear concept underlying this association. The fatal triple in MASH is obesity, type 2 diabetes, and cardiovascular disease. The heart, obesity, liver, and diabetes cause the fact that there is a need for comprehensive care with a multidisciplinary and multi-stakeholder approach in these patients. Remember that approximately 75% of people with type 2 diabetes, as we said, 75, have MASLD, and also 90% of people living with obesity have MASLD. Because of that, I think this is, of course, medical grand rounds. And as I said, there is a need for a multidisciplinary collaboration around this condition. Last year, we published an opportunity for collaboration, for example, between cardiology and hepatology, because actually some cardiovascular drugs have a possible positive impact on liver steatosis and fibrosis. And the other side, there are some MASLD targeted drugs which can have also cardiometabolic positive effects. Some of them are still under development in phase 3 clinical trials. The most important, and this is very important in clinical practice, but the most important risk factor, the most important feature that actually increases the prognostic value in patients with MASLD is fibrosis. I have studied fibrosis now for 22 years, actually, probably. And liver fibrosis is the major driver of all complications associated with any liver condition, including MASLD. In this meta-analysis that we published a few years ago, we actually showed that per one increase in fibrosis stage increases all-cause mortality, again, underlying that this is a multi-system disease. And you can see, of course, that as long as the fibrosis increase, there will be also an exponential increase, especially when you go towards cirrhosis for all-cause mortality. Because of that, in clinical practice, we actually recommend that we should not screen the general population for sure for liver fibrosis due to MASLD, because you can see here that the prevalence of liver fibrosis in the general population is relatively low. We spoke before about 2, 3, 4% in a primary setting. However, in a tertiary, quaternary setting, especially in people with type 2 diabetes, this prevalence rises by 3 times, 15%. We estimate of people seen in endocrinology clinics have actually some forms of advanced fibrosis. Because of that, all the guidelines, and this really I want to show you, liver guidelines, diabetes guidelines, obesity guidelines, and even American Heart Association in 2022 have released a viewpoint on the topic that screening of MASH and related advanced liver fibrosis is actually recommended in at-risk patients, which include people with type 2 diabetes and people with obesity and another comorbid condition. So very important. This is something that actually is recommended since many years, but by the European guidelines, repeated again by the European guidelines for the liver, for diabetes and obesity in 2024, and also recommended by the American Diabetes Association guidelines in 2025. So how do we do this screening in practice? So actually, we cannot use liver transaminases because there is a high proportion of MASLD patients with normal ALT. According to studies, to current literature, 25% of patients with MASLD and 90% of patients with MASH have actually persistently normal liver transaminases. So we cannot actually use liver transaminases to screen for advanced liver fibrosis. However, we can use biomarkers and transient elastography. These are the tests that are mostly recommended by guidelines. The FIB4, which is based on age, AST, ALT, and platelets, and the transient elastography, which is here available. We have two machines, actually, one at the SIM and one in the hepatology clinics, to screen for liver fibrosis. And how do we screen in clinical practice? So according to the guideline, any patient with type 2 diabetes or with obesity and another cardiometabolic risk factor, or of course, if there is an elevation of liver function test that isn't explained, should undergo screening for liver fibrosis through FIB4. This is a simple test, AST, ALT, platelets, and age. If FIB4 is less than 1.3, there is very low risk. The negative predictive value is over 95%, very low risk of having advanced fibrosis. If it's in between 1.3 and 2.67, then this is called a gray area, and there is a need for a fibroscan. If the fibroscan is over 8, then the patient actually needs to be referred by a gastroenterologist for further management and possibly a liver biopsy or a third-line non-invasive test. Also, if the FIB4 is more than 2.67, also this is a patient who may have a higher risk of having advanced fibrosis, and it can go directly through the referral to gastrohepatology. This is the algorithm from the European Liver, Diabetes, and Obesity Associations. And this is really a preview. I am actually the co-chair of the Diabetes Canada first chapter on MASLD with Dr. Kim. And this is a preview. It's not published yet, but actually we recommend very soon with Diabetes Canada a kind of similar screening algorithm for patients with type 2 diabetes. So any patient with type 2 diabetes actually or pre-diabetes should undergo FIB4, and then the algorithm that I mentioned before. If it's less than 1.3, no need for referral or further testing. If it is between 1.3 and 2.67, there is a need for fibroscan or other second-line tests. If it's more than 2.67, direct referral can actually be done to gastrohepatology. So now, the condition is extremely frequent. There is a need for screening for liver fibrosis in patients who are at risk for MASLD. The at-risk populations we defined are people with type 2 diabetes, people with obesity, and at least one cardiometabolic additional risk factor. What we do with these patients in terms of management, in terms of therapeutic approach? Well, the cornerstone of the approach to MASLD remains non-pharmacological approaches, which is weight loss. So we know that if a patient loses more than 5% of the body weight, it will improve steatosis. If he loses more than 7% of the body weight, it will improve MASH. And if he loses more than 10% of body weight, it will even improve fibrosis, even cirrhosis. There is long-standing now literature from bariatric surgery patients which show that even cirrhosis can be regressed after an important weight loss. The approach to weight loss should be a combination of course, of dietary instructions and also exercise, and bariatric surgery where indicated. And I want to show you that the Mediterranean diet, it's actually the most studied diet in patients with MASLD. There are several trials which show that it significantly decreases BMI, triglyceride, and insulin resistance. So Mediterranean diet is actually the most recommended across the liver guidelines. And a few hints on some of the components of this diet. First of all, coffee. Actually, there is many studies that show that more than 3 cups of coffee per day decrease the risk of MASLD, and also there is less association with fibrosis, to the point that guidelines currently recommend to consume at least 3 cups of coffee per day. It's not espresso, unfortunately, it's filtered coffee. I'm Italian, I would prefer espresso, but espresso was less associated, it's more filtered coffee. Probably this effect is actually due to the antioxidants actually contained into coffee, caffeine, chlorogenic acid, cafestol, and of course, we recommend patients to avoid sugar with the coffee. What about fructose? Actually, fructose is much worse than glucose for liver. It's actually, I usually tell my patients, it's like poison for you. In this study, it's a relatively old study, Gastroenterology 2017, but I really love this study because in 41 children with obesity and high habitual sugar intake, they gave 9 days, not 9 weeks, 9 days of meals with the same energy and macronutrient composition, but with the final fructose content less than 4%. And at day 10, there was a significant reduction in liver fat, visceral adipose tissue, and the low of lipogenesis. And I want to show you that actually the relative change in liver fat was 30% after 9 days. This is really showing us how impactful can be fructose on the liver health. Because of that, we, of course, recommend not to consume any of the beverages which contain fructose. Fructose, in fact, increases oxidative stress 100 times more than glucose in terms of reactive oxygen species. It's really amazing, unfortunately, in my opinion. It may also induce mitochondrial dysfunction by lipotoxicity. I would like now to touch on pharmacotherapy. Now there is an explosion of pharmacotherapy in the MASLD world, and I think there is a lot of overlap between hepatology, endocrinology, internal medicine, all working together to try to find appropriate pharmacotherapy for this frequent condition. The first point is that I think the renaming of NAFLD to MASLD is actually very important also for therapeutic reasons, because there is more precision in diagnosis. MASLD better reflects metabolic origins, helping refine target population for clinical trials and treatments. Also, there is a shift towards more metabolic pathways for drug development, right? So targeting insulin-resistant lipid metabolism. And finally, of course, personalized medicine, because targeting the MASLD nomenclature versus NAFLD, there is improved stratification, which enables personalized therapeutic approaches. And now, so how we can reach the goal of having finally many FDA approved and hopefully Health Canada approved medication for MASLD, for MASH, basically for fibrosis. According to the FDA, accelerated approval, it's based on histological endpoints, which means that any pharmacotherapy for MASLD should meet resolution of steatohepatitis and no worsening of liver fibrosis, or improvement in liver fibrosis and no worsening of steatohepatitis, or both the resolution of steatohepatitis and improvement in fibrosis. This is for accelerated approval. For full clinical approval, a pharmacotherapy for MASH should actually show improvement in clinical outcomes. So this is the number of clinical trials that are actually last year in MASH and NASH across the world. You can see 519 in the United States, 8 in Canada, 236 in China. So really there is an explosion of clinical trials. This is really the new disease, inside the old new disease in the liver world. But I want really to show you some data of the most advanced of these molecules. First of all, by underlining that actually last year, there is the first FDA-approved treatment for MASH. So this is actually the resmetirom. Resmetirom is actually based on the thyroid function. Thyroid hormones regulate hepatocytes and a variety of cell types in the liver. Liver cells express thyroid hormones receptors and are affected by thyroid hormone action. Low TH function can result in hypercholesterolemia, an important step in hypothyroidism-induced MASLD. And TH also regulates mitochondrial biogenesis. So actually, TH performs clinical function in energy and metabolic balance, and it plays a role in the pathophysiology of MASLD. Because of that, resmetirom was actually created and now approved. Resmetirom is a liver-targeted thyroid hormone receptor beta-selective agonist. THR beta, actually. It's actually predominantly expressed in the liver, kidney, and pituitary gland. And TH effects on the liver include de novo lipogenesis, fatty acid beta oxidation, cholesterol metabolism, and so on. So this is actually targeting important pathways in the pathogenesis of dysfunction and lipogenesis in the liver. These are the data which actually led to approval by FDA of the MAESTRO-NASH trial, phase 3 of resmetirom, where you can see that resmetirom actually met both endpoints according to FDA, which was MASH resolution with no worsening of liver fibrosis and fibrosis improvement of more than one stage without worsening of MASLD activity score. Side effects include gastrointestinal, mostly gastrointestinal side effects. I just want to underline that unfortunately resmetirom is not yet available in Canada, and hopefully in the near future we will have some news about the process in Canada. Incretins. Incretins is the new probably penicillin, someone said some time ago. Incretins, GLP-1, glucose-dependent insulinotropic polypeptide. So these are really pleiotropic effects across the body. Of course, we will focus on the liver, but I would like just to remind to all of us that they actually act on glucose regulation, reduce hepatic fat, have anti-inflammatory effects, reducing oxidative stress also, and also may have some effect on slowing fibrosis progression. Here are the data which were presented in November 2024 at the American Liver Meeting in San Diego, the phase 3 study ESSENCE, the data for semaglutide in MASH, which show actually that there was a difference in the response in terms of resolution of MASH, no worsening of liver fibrosis, of 28.9% in the treatment arm versus the placebo arm. And also there was a 14.4% reduction improvement in the treatment arm in terms of improvement in liver fibrosis. We know common side effects of semaglutide include gastrointestinal effects, but these are really also the first data that show improvement in liver fibrosis in a phase 3 trial of incretin-based therapy for MASH. In the same year, actually, the phase 2 data for tirzepatide were published in New England Journal of Medicine, again showing actually improvement in terms of resolution of MASH with no worsening of fibrosis when tirzepatide was used versus placebo. Same year, again, New England Journal of Medicine, phase 2 of survodutide, which showed histologic improvement in MASH in terms of, also in terms of decrease in liver fat content and improvement of MASH histologically. So also this, actually, both of these studies are now moving, obviously, to phase 3, given the positive results. This is a study, actually, that coming from our very own McGill that we just published in Diabetes Care, and I think from Dr. Azoulay and Dr. Suissa, where I think it's very important to be reminded that a cirrhotic population is a special population and needs dedicated validation of this data. This data that I showed you before were in non-cirrhotic patients, so stage F2 and F3 fibrosis, not F4, which is cirrhotic stage. In this study that we just published, actually in Diabetes Care, 25,000 patients starting in GLP-1 receptor agonists and 186,000 DPP-4 inhibitors. GLP-1 receptor agonists actually were not associated with the incidence of cirrhosis in terms of protective effect. On the other side, in 33,000 patients started on SGLT2 inhibitors, SGLT2 inhibitors were associated with the reduced incidence in liver cirrhosis. Of course, this is, it's just a data registry-based study, but I think that these data show that we need validating studies specifically in the cirrhosis population. And the last but not least, peroxisome proliferated activated receptors. These are actually very known by cardiologists and by our colleagues who work in this in the field. So composed of different isotypes, they're actually regulating lipid metabolism, and in the liver, they seem to regulate inflammation and fibrosis. So many of the studies in MASLD using PPRS were actually terminated because of no response. However, there is one, which is lanifibranor. It's a pan-PPR agonist in MASH. The phase 2b study published in New England Journal of Medicine a few years ago, now they are already in the phase 3, they actually showed improvement in MASH compared to placebo. So I think this is also a very promising molecule, and probably the future would be a combination of incretin-based and antifibrotic molecules like pan-PPR agonists. So this is the summary of the treatment recommendation in MASLD and MASH from the American Diabetes Association. So I really love this image because it gives you a stage-by-stage approach. So the base in terms of comorbidities, obesity pharmacotherapy and diabetes pharmacotherapy is mostly GLP-1 receptor agonists, dual GIP and GLP-1 receptor agonists, and also SGLT2 inhibitors in the European Association liver guidelines in terms of diabetes pharmacotherapy, and also here. It's important to remember that these medications are to be avoided in patients with decompensated liver cirrhosis, and in terms of diabetes pharmacotherapy, only use insulin. But on the left, you can see that the cornerstone of the treatment, it's always lifestyle modification. This is from the Diabetes Canada chapter that is about to be published, and I want just to give you again a preview. You can see that we target kind of the same. We aim at sustained weight loss, of course. Anti-glycemic agent, we suggest semaglutide or pioglitazone in patients with MASLD. And statins are an essential component of the treatment for MASLD. They don't improve MASLD, however, they reduce the cardiovascular risk factors, and remembering that the number one cause of mortality in these patients is cardiovascular disease. And also, there are some evidence showing that statins can even lower portal hypertension in patients with cirrhosis. So we have to use statins very generously in patients with MASLD. So I think that as a part of an holistic approach to a multi-system disease, we cannot forget the pillars of obesity treatment. Of course, we have to target nutrition, physical activity, and medications. However, it's also very important to remember that these patients, in 1/3 of these patients actually live with a binge eating disorder. For example, this is an article that published one of my fellows, where we really underlines the importance also of behavioral interventions. So probably also psychotherapy and behavioral intervention are especially useful in these patients. So this is really the overview of what I believe as an holistic and sustainable stage-by-stage approach to this condition. For sure, diet and physical exercise is across all stages of MASLD, also cognitive behavioral therapy. GLP-1 receptor agonists probably, for now, they are safe for sure in cirrhosis, in compensated cirrhosis, although they didn't show yet effect on MASH specifically. And resmetirom is not available in Canada, but for sure it can be targeted in the countries where available, stage 2 and 3, and lanifibranor and others when they will arrive. I would like to finish by saying that our hepatology unit is serving great in Montreal for FibroScan since 2013. We have served over 1,000, actually 10,000, 15,000 of patients. Currently, we have been instrumental in getting a reimbursement for FibroScan. Quebec, since 2013, is still the only province in Canada which has a reimbursement for FibroScan. Outside Quebec, patients have to pay for this, so I think we should be very proud for that. And finally, and here we have Dr. Dasgupta, who actually one of the applicants in this grant that we just received from the CIHR and the FRQ-S, where we will actually looking at improving the experiences of people with type 2 diabetes in terms of screening and care pathway along the cascade of care to access MASLD care. So you will see us around at some point coming to the endocrinology clinic, internal medicine clinic, to recruit patients who may benefit from this study. So I would like really to thank you all. These are the summary. MASLD is the most prevalent disease globally. Type 2 diabetes and obesity represent the main condition associated with MASLD and MASH and liver fibrosis. Screening for advanced liver fibrosis is recommended in people with type 2 diabetes and metabolic syndrome. Current therapeutic approaches to MASLD include lifestyle and some pharmacological options. Numerous agents are now actually in development in phase 2 and 3, including GLP-1 receptor agonists, pan-PPAR agonists, and others. But I think that really MASH is a multisystem disease, and therapy should actually always target an holistic approach to this multisystem condition. Grazie, thank you very much. Venice and Montreal.
So thank you, Giada, for this excellent talk. And this is the new epidemic coming down. So we're going to open up the chat. There's some questions here. A lot of questions, Giada.
That's nice.
Okay. So it seems that this is a question. It seems that we need to target, all we need to do is target obesity. That would reverse the NASH epidemic. Is that?
I totally agree. This is a question from Dr. Bernasco, from Sasha. Hi, Sasha. So I think, you know, the most of the, and I think also Kaberi would agree with me that really obesity is what is driving MASLD and type 2 diabetes obesity. I think that, for example, as Canadian Association for the Study of the Liver, we are working with the awareness campaigns. We started going into the schools, actually. We started FibroScan young children to show them how important is the liver, because most children and adolescents don't even know what the liver is for. You know, okay, it's just producing bile or some yellows. So we're trying, you know, to do some awareness campaign, educational events, of course, also to really make people love the liver and understand how liver is a crucial organ. And I think this should be done also at the obesity level, metabolic level. So really lay lectures, awareness campaigns, I think they are fundamental. And as we said, food insecurity, socioeconomic status, so the lack of access to positive food. We say to eat Mediterranean diet, but if people don't have the money to buy it, so we maybe need to write a prescription, Mediterranean diet, instead of semaglutide. Thank you, Sasha, for the question.
So maybe just one question for myself, Giada. We get an inordinate amount of referrals, patients who get ultrasounds for various reasons, and you get fatty liver.
Yeah.
And we get a huge number. And how do we navigate through all these? I mean, is it just through FIB4 or risk factors? Like, what do we do? Because
yeah, actually, that's an excellent question, because we have we also put this in Diabetes Canada guidelines in the chapter, because incidental finding of hepatic steatosis, obviously with the prevalence of 32%, is very frequent. So what we usually recommend is that, of course, in our center, we are a tertiary care center, so of course we have access to FibroScan, and we are always happy to do FibroScan for our colleagues. Usually when there is hepatic steatosis, the first step would be to do the FIB-4 actually, and to enter this care pathway that I showed you. So the FIB-4, if it's less than 1.3, you don't need to proceed with the FibroScan. If it's more than 1.3, you may need to do FibroScan. So in case of hepatic steatosis, we would need the FIB-4 to navigate, yes. And, especially for external referrals.
And in the community, are they aware of this, do you think?
So actually, that's an excellent question. We are organizing many educational events with the Canadian Association for Study of the Liver, with our colleagues, primary care physicians, and also involve them actually. We are also with Tianyan, with Dr. Shen here, we are starting some educational events across Canada. Because we really think that even the implementation of this pathway should integrate the suggestion from primary care physicians, because they are the main users, right, of this pathway. So we would like to hear from them which are the barriers, which may be the facilitators, in order to proceed with large-scale implementation of this pathway. That's an excellent point.
So other questions, there's a lot of questions here relating to fructose and coffee. And so let's just look at this. So
I like actually the question from Dr. Weissman, if I may. So Dr. Weissman, why are they still allowed to be sold? I don't know, actually, Jeffrey, I just wanted to tell you a small anecdote. Last year, during March break, I was in Toronto for actually the Canadian Liver Meeting with white children. We stopped in one of these food halls to buy, some food. And in the menu, the fructose beverage was included in the menu. We asked, we want some regular water. You have to pay extra, actually, for the regular water. So, these are small interventions. The water should be included in the menu, not that you have to pay extra. Of course, not many will do that, right? Of course, we did it, but...
So staying on the theme of diet, is coffee the only antioxidant that's beneficial in MASLD?
So that's actually a very good question. There are less data, but there are also, for example, some data on green tea. They are not as strong as for coffee. In fact, green tea is not recommended. But for example, in terms of antioxidant, vitamin E has been used and recommended by the guidelines for many years, since the pivotal PIVENS trial, which was published in New England Journal of Medicine in 2010. We have been using a lot of vitamin E. It's just an antioxidant. It doesn't probably improve fibrosis, but it reduced inflammation, necroinflammation in the liver, and it reduced also liver transaminases. So I think antioxidants have a lot of potential. I mean, obviously, when there is already fibrosis, you would also need an antifibrotic medication. But in the clinical practice, something that we use a lot.
So a question from Dr. Rosenblatt, higher up there, where he asks about the folic acid and homocysteine and development of MASLD. Do you know anything about that folic acid? Let's talk about mouse models.
Yeah, I mean, I'm not sure how much there is in terms of. For sure, there is some. Yeah. You want to? There is Dr. Rosenblatt David, here. Hello.
Hi, David.
Thank you. So I don't know if you know Dr. Rosen, but she's one of the senior people. She's getting close to retirement, who's worked for years. And she's been concerned because of, as you know, this fortification of folic acid in grains. And people have been concerned that people also take multivitamins, you get higher levels of free folic acid. And she's been studying the effect of this in mice at predisposition for high homocysteine, low folates, and has shown hepatic disease, non-alcoholic hepatopathy in the mice. So she has a whole literature on this that she's been studying for 5 years. And I wondered whether you had interacted with her and thought about this public health issue.
Thank you very much for your question. Actually, now I see your question more in detail. So actually, the MTHFR is one of the polymorphisms that has been associated with MASH indeed. I don't know for specific interventions, for the result of specific intervention with the folic acid, but this is one of the polymorphisms that has been associated with MASH. And with
although we don't measure it clinically anymore. It's not measured clinically anymore. It's been taken off the menu. But she's certainly interested in this on a research basis, and you might be interested in getting in contact with her because she's very...
Thank you. That's actually excellent suggestion. Thank you very much. We're always happy to collaborate, Dr. Rosenblatt.
So there's a question from Oral Chercheur. So if you have a patient with a FIB score between 1.3 and 2.67, can a primary physician or in general internal medicine or
yes, absolutely. Actually, Dr. Chercheur, everyone I show in the slides that we have some referral forms for FibroScan. So anyone we received the referrals from GPs in the Greater Montreal area, from internal medicine doctors, rheumatologists. We even have dermatologists referring when they have to do, some hepatotoxic medications and they found some steatosis or they are concerned. So you just need to send us the referral and we will do. If the FibroScan if the FIB4 is more than 1.3, we will book the FibroScan for you and for your patient, no problem.
Okay, question by Ingrid Hinks. So do we know the contribution of fructose versus alcohol? Is one more?
Oh, that's also, thank you very much, actually, Dr. Hinks. This is an excellent question. I didn't show the data on alcohol. So according to the guidelines, basically, of course, alcohol is deleterious in MASLD, and it is, we recommend to patients to drink absolutely no alcohol in case if there is F2 and more fibrosis, so if there is what we call significant fibrosis. However, the guidelines also state that potentially any amount of alcohol in patients with MASLD could be deleterious. So, of course, we have to do kind of a balance, not to be too strict, otherwise afterwards the patients don't listen to us anymore. So usually I use, for example, the Canadian addiction guidelines that were endorsed, I think, a couple of years ago, stating that less than 2 drinks a week does increase the risk of overall mortality. However, this is for general MASLD. However, if a patient has at least F2 fibrosis, it should refrain completely from drinking alcohol. Thank you for bringing that point.
Yeah, question by Dr. Moret. Is there any relationship between MASLD and sarcopenic obesity?
Yeah, that's another excellent question. Thank you very much, Dr. Moret. So, actually, we looked, we also did some research in sarcopenic obesity, and there is for sure there is an increasing amount of data showing that there is a link between sarcopenic obesity and MASLD, to the point that this actually may even increase mortality in patients with MASLD. Research has started a little bit later on this specific topic, but there is I think that there is a huge potential in this research setting. Thank you very much for your question.
Perfect. And so we have 2 more questions. So last one about fructose in high doses. For example, is that the problem?
Yes, it's actually exactly the high doses and also their natural sources of fructose, as you said. Exactly, right, absolutely. This is both of them that you said. This is Dr. Arieta.
Yeah. Perfect. And Patricia Zanelli asks about fibroscans that are done by radiology. Are they okay?
Dr. Zanelli, hi, how are you? So actually, they don't do fibroscan, they do shear wave elastography, right? At least in our radiology, okay? So shear wave elastography has been nicely validated, as a fibroscan. But the most important thing, I think, is that the number of measurements has always to be the right number of measurements, always at least 10 valid measures with an interquartile range less than 30% on the results. So as long as these quality measures are respected, so shear wave elastography is as good as fibroscan. Yes.
Actually, there's one question by Sasha. Why doesn't our healthcare system cover CBT?
Sasha, I would like also to know. I think honestly, I think maybe there is not as much interest as in pharma drugs. I mean, they probably financial interest is different, but I think CBT has an amazing potential, because really we actually we go upstream, right, to target the root cause of obesity and the root cause of binge eating, for example. So I think if we could have access to CBT at a more widespread level, probably the repercussions, positive repercussion, will be great. In fact, at the Canadian Liver Meeting now, we had a lecture on CBT and on behavioral interventions, and it was the most, everyone was so interested in that because it's something so different, but so potentially impactful. I think there is a question from Kabari.
Just because the head of medical biochemistry is willing to integrate the FIB4 into.
Oh, thank you.
Who is he? That's fantastic. That's wonderful. She put FIB4 in your mouth. Yeah.
Thank you, Kabari.
Okay, you know what? One last question by George, Dr. Fantis.
Kabari said that, Patrizia is asking, Kabari said that the head of the biochemistry said that
Dr. Blank.
Yeah, Dr. Banks said that he is willing to integrate FIB4 in our, that's very nice. Thank you.
Wonderful, David. Just last question by Dr. Fantis about SGLT2.
Yeah, Dr. Fantus, hi, how are you? The recent analysis of SGLT2 inhibitors and GLP-1 showed the effectiveness of SGLT2, but these are not in the guidelines. Should we use this also as primary therapy? Great, thank you. So actually, SGLT2 are both in the ADA guidelines for treatment of diabetes, of course, not for treatment of MASLD, and also in the guidelines of the European Association for Study of the Liver, Obesity, and Diabetes. So they are recommended to treat comorbidities, specifically diabetes, in patients with MASLD, but we don't have evidence specifically on the effect of MASLD. There are some data showing potentially reduction in liver fat, actually, even with SGLT2 inhibitors, but more data are needed for the specific effect on MASLD. Thank you very much.
Okay, well, on that note, we're going to end today's session.
Thank you.
Giada, thank you so much for such a great talk and basically explained to us MASLD so well. Thank you very much.
Thank you very much.